cardiac surgery, which if we have time, we can get there, but it's really not the most important thing that came out of ACC. So, all right, thanks, Ryan.
We all know the most important thing that came out. Is this thing on? Because it actually might help me out.
There's a mute button on there.
Got it. Oh, yeah. All right, so it's May the 4th today, which is Star Wars Day, which is appropriate because I sound like Darth Vader, so exactly. So my voice might hold out 2 minutes, and then this is going to be interactive. I'm going to have you guys interpret forest plots and graphs and stuff. So this is Partner 2, presented at ACC in Chicago. So quick background, as we all know by now, with all the TAVRs we do, prior RCTs have shown, wow, this is awful. This already stinks. All right, Cooney, you want to read my slide here?
Superiority of TAVR over medical therapy in inoperable patients with severe AF. Non-inferiority compared to TAVR in high-risk patients with severe AF. Increased operator experience on lower profile devices have led to use of low intermediate risk patients evaluated with small observation studies, but no randomized control trial. This is the first RCT to examine TAVR versus TAVR.
Perfect. Perfect. All right, so Partner 2 is looking, for the intermediate cohort, this is looking at the Edwards Sapien XT, which is the second generation valve. So it's balloon expandable, and like Dr. Cooney said, the second generation has a lower profile. So the original Sapien, you needed a 22 or 24 French sheath. This one requires a 16, 18, or 20 French sheath. Here, for those who haven't seen it, here's the stent loaded on a balloon, which is on the delivery catheter, and then there's a sheath that goes in with the device to get it into the thoracic aorta, and the sheath is withdrawn, exposing the balloon and the catheter blown up in the annulus. And here's the available annulus sizes. All right, so again, we all kind of know the procedure, so I didn't go into the details, but just pertinent findings or pertinent kind of tidbits about this trial. So patients with non-complex coronary disease, which was they couldn't have left main or they couldn't have a syntax score above 32, they could undergo PCI or CABG at the discretion of the heart team. Everybody got 81 of aspirin and were loaded with Plavix, and then had at least 1 month of Plavix along with indefinite aspirin. So multi-center prospective, 57 centers in the US and Canada. They enrolled 2,000 patients between December of 2011 and November of 2013. So this was intermediate risk, so STS had to be between 4 and 8%. They could be less than 4%, however, if they had other risks that aren't captured by the STS. So things like cirrhosis, malignancies, anemia, things like that the STS doesn't capture, if they thought it was appropriate, could still be enrolled. All right, so pertinent, I should get closer, sorry. Pertinent inclusion criteria, so they had to be senile degenerative AS, it couldn't be a bicuspid valve, kind of standard definitions for severe aortic stenosis. They had to be symptomatic with New York Heart Association class 2 or greater symptoms, and then they had to, derive benefit. So lots of exclusion criteria, pertinent ones. They couldn't have had an MI within 30 days of the intended treatment. As I said, it had to be just degenerative AS. It couldn't be unicuspid or bicuspid. And then also, they had to have a calcified annulus. It couldn't be a non-calcified valve. They couldn't have mixed disease, meaning AI greater than 3+. I mentioned they couldn't have complex CAD. They couldn't have undergone a balloon aortic valvuloplasty within 30 days of the planned procedure. And EF had to be greater than 20%. So primary endpoint, there were lots of secondary endpoints, but primary endpoint was a composite of all-cause mortality and disabling stroke, which is a modified Rankin score of more than 2. And those were all independently adjudicated by a stroke neurologist. All right, so here's table 1, which projects fairly well. So fairly, even split. Notable that most patients were New York Heart Association class 3 or 4, and most were male. Otherwise, pretty even statistics across the board. What you'd expect for a intermediate risk. I'll talk about it at the end, but even though an STS of 4 to 8, it's still a pretty high risk population. All right, here comes the patient or the audience interaction. So who wants to interpret? This is the primary event. Jeremy, you're sitting nice and close.
Less than 1, so maybe their TAVR looks like it might be trending towards better, but the confidence interval one, so there's no.
Perfect. And that's for intention to treat and as treated on the right. So here, I guess I don't have to pick on people. My voice is holding out okay. So here's breaking it down just by transfemoral access. And so here you can see the hazard ratio lands exactly on 1, p-value 0.05, so suggesting maybe superiority of TAVR over SAVR. But of course, it wasn't intended to be a superiority trial, so hard to make that claim, but at least non-inferior, but trending towards superiority for the transfemoral group, both in intention to treat and as treated cohort. Do you mean like how many crossed over in the? Well, no, so intention to treat includes the few patients that crossed over to surgical, which I apologize, I don't have the exact number, but I know it was quite low. Yeah.
775 were analyzed for TAVR on the last assessment to treat.
Oh, yeah, yeah.
772 actually got the TAVR. They were in the S3 cohort, so very few.
Glad he's here. All right, and this actually does project pretty well. They always put everything on one huge slide, and it's difficult to fit it on one screen. But here are subgroup analyses. So basically, everything crosses the midline. There was no significant differences. Although again, if you look at the bottom, the transfemoral group again seems to favor TAVR over surgery. But otherwise, really no significant differences for these pre-specified end groups. So here's, they also looked at echocardiographic findings, so valve area and paravalvular leak. And so similar to what we've seen in other trials, TAVR did better than surgery with regards to aortic valve area, and that was a durable response out to 2 years. And on the right, we're looking at paravalvular leak. As expected, and as we'll see on the next slide, there is more paravalvular leak in the TAVR group, and specifically more moderate to severe paravalvular leak. Correct. This is all XT. Yeah. Mm-hmm.
You need to trade that off for more EV block though. Like a 10 or 11%. So anytime that you decrease paravalvular leak.
So here they took patients with paravalvular leak and compared outcomes between groups. And so not unexpectedly, no significant difference between the mild and the none or trace group in regards to mortality. There was a significant difference when you compared the none or trace group to the moderate to severe group, and that was significant. So higher mortality in patients who develop moderate to severe paravalvular leak, something that we've seen in other trials and makes intuitive sense. Now this is the slide that I knew wouldn't turn out very well. Hard to fit it all in one slide. But this is just a breakdown of all the clinical endpoints by 30 days, 1 year, and 2 years. And so things I will highlight. So again, similar to prior trials of TAVR with the core valve, there were more major vascular complications in the TAVR group, and that was statistically significant. However, there were fewer episodes of life-threatening or disabling bleeding, acute kidney injury, or new atrial fibrillation. So all those favored the TAVR group. it's not on this slide, but I also will say there was a shorter ICU stay and shorter hospitalization for TAVR, and those were both statistically significant. Yep, and that was my next point. So absolutely no difference or statistically significant difference in permanent pacemaker placement. And just as a reference, that's in comparison to, this is the core valve trial, so 2-year outcomes of the Medtronic core valve self-expanding valve. And in that trial, there was a statistically significant increase in the number of pacemakers implanted with core valve as opposed to surgical valve. I can tell you. 11 and 12%. Yeah.
This is kind of a very specific question, but do you know if they had specific criteria for how they decided what pacemaker and which people, or is it just
No, it's a great question. It'd be nice to know the specifics, and they don't really give those. They just say at the discretion of the heart team. Yeah, because we've had a lot of those, prolonging left bundle, never have heart block. Do we put in a device or not? And unfortunately, this trial doesn't really address that question. So here are kind of takeaways from this trial. So TAVR with the XT valve was non-inferior to surgical AVR with regard to the pre-specified primary endpoint of all-cause death and disabling stroke. And again, this is at 2 years. Valve gradients were lower and areas were larger with the SAPIEN XT compared to the surgical valves, again at 1 and 2 years. The secondary events or endpoints that favored TAVR were less major or life-threatening bleeding, less acute kidney injury, and less nuance of atrial fibrillation. And then, like I mentioned, there was a shorter duration in the ICU and hospital. However, there were more vascular complications with TAVR compared to surgical intervention, and that's something that we've seen in other trials. And then again, this trial, suggests the possible superiority of TAVR over surgical AVR in the patients who could undergo transfemoral approach, but we would need more prospective evaluation to really make that claim definitively. So next steps, and then, hoping to get some more discussion from you guys. So like I mentioned, the TAVR device has gotten better. It's lower profile, which, in theory should allow it to be used transfemorally in more patients, and which may also reduce the paravalvular leak. And then also we have newer and better embolic protection devices, which in theory might lower the stroke risk and could sway the results of these trials even more. You have to weigh that with the fact that surgical AVR is also improved and there's more minimally invasive techniques. So we'll have to, future trials will have to continue to compare the two. It's hard to make conclusions based on this alone. This was only 2 years, so we also need the 5 and 10 year data. And then we also need just additional trials in intermediate risk, because this is the first major RCT that we've seen in intermediate risk patients. There are 2 that have just finished enrolling. One is SIR-TAVI, which is a core valve trial in intermediate risk patients. That one should be underway soon. They have finished enrolling. Then the UK TAVI trial will just have finished enrollment as well. That is looking at all devices commercially available at this time that will include intermediate and some low-risk patients. So SIR-TAVI will be just core valve, similar to what Partner 2 is doing with the SAPIEN XT, and then UK TAVI will be comparing core valve, SAPIEN, and Lotus valve. So that was all I had. We already did some kind of discussion points. I think one of the big things I didn't emphasize though is the lower sheath size and the lower delivery system size will hopefully allow more people to have transfemoral. And as we can see, it seems like when you can do transfemoral, the outcomes definitely favor TAVR over surgical AVR. But we'll need more prospective trials to examine that. Dr. Francis? Correct. Yeah. Partner 2.
Probably have a little discussion about that over the next the expectations are that this may become one of the leading procedures
So I think one question that needs to be answered still is the durability of these valves. We have 10-year data for the original first generation valves. If we can get longer term data and they do well, then certainly we could use these in younger, lower risk patients. Alternatively, this is just something that, people have mentioned. Even if we're seeing the durability isn't great beyond 10 or 15 years, the opportunity to do valve in valve is still an option. Maybe not ideal in a low risk patient to make them do 2 procedures rather than 1, but still could be an option. What do you guys think?
The downside is, they're still doing cut downs and because they don't have more here, good catheter, what you doing next. They're very comfortable with cut down. We are not comfortable with cut down. So we that here we will cut down and we will show. Okay, so that's that. And I would say pocket of place that they are heavily dominated by Milwaukee is one of them. Vienna is one of them. Arizona is one of them. So there are a couple of places that interventions are happening. Other side, surgeons behave like an obstruction. Every case they're going to go, they kind of say, no, I can't. Local kind of program, they never do. They like use like 5 or 10 because surgeons will block them completely in their society, but what they do not realize is it's going to come to our site, it's going to come to the city, it's going to come to the state, it's going to come everywhere. You can't block your institution. All what you are doing, you are doing your institution by your practice. But all the other stuff is so that's that. In our center, we can afford kind of really kind of hyper. But most of the hospitals are pretty tough. All of them not really exception. So when the intermediate we're only able to swim food. So the problem will come at that time is the council. The safety. Most of the things are not good. So it's easier to I do, but I'm not really straight through the water. So surgeons are not really, oh yeah, you can. Now we are being bread and butter work or the aortic graft surgery is one of the surgeries. It's one of their kind of core training. So I think they are really confused. But then the problem yes, that is 2 surgeons. At least now, 2 surgeons at the pediatrician and the pediatrician. So they're not going to say hi, but and the event turns around and say, no, you don't have to have that, or something else. You know, it's never going to say a 65-year-old guy with the FDA code 4 that it is higher volume for the cooperative. They don't say that. So then I think we have some problem unless we say, you know what, let's do 50, you take care of the concept, but it's all do the program together. So that's what I think that would be the approach. Otherwise,
We have with the reimbursement.
so reimbursements are it's regional. So if you go to Stanford, they get about $90,000. If you go to some center, yeah, on average. Well, we are getting so
We lose money with
we lose money. We are losing. So once that is taken into account, critical value of course. So you know, right away we are we are paying pretty much more for that. So the last time we looked at it, and we go into patients, or go to the achieve and
hospital can pay a little more.
yes, they are. Always.
How about general anesthesia versus,
General anesthesia was infection. You know, most of the people are doing all these kinds of things. I know Vancouver. I was in Vancouver 2 months ago. Oh, yeah, education. That is Vancouver. Study also goes. Yeah, right. So there's a big push for it. Then asking your question about the guy was asking about the it's a real. Not that, and do that. This was supposed to be okay. So the first few cases we had the dry run for patient fashion, how soon can we get this patient to watch it go on? It was the same time. The patient crashes in the 4th floor of Mary Brown. Go to O1, take some appointment because we have other surgeons. In some cases, the patient, it takes some time. It's not like somebody is open on waiting for the patient. And it's taking a while. We have to arrange it. It's not really everything. We have all the surgeons, all the physicians, get the room ready. It takes about 40 minutes to 1 hour. So we did a dry run. Calling from Mankato to say, okay, now we need this done right away. How soon can you put it in? But during that kind of downtime, getting those programs is quite issue. So, but now,
I think you all are witnessing one of the great transformations in our It's interesting what's happening, is also the data that we're getting now winds up being a 2 years delayed, and then the guidelines are gonna be way behind, you know, the target keep up. So every time it's, yeah, every time the valve gets better, lower profile, and less fair valve, all these things.